There is one common thing millions of older adults do before bed because they believe it helps them relax. Some call it a nightcap. Others describe it as just one drink to help me sleep. But for a person with high blood pressure, an irregular heartbeat, untreated sleep apnea, or a history of stroke, that bedtime habit may create the exact conditions the heart and brain do not need during the night. The habit is drinking alcohol shortly before going to sleep, not because one sip automatically causes a stroke. It does not. The danger is that alcohol can disturb your heart's electrical rhythm, worsen nighttime breathing, interact with common medications, and contribute to unhealthy blood pressure patterns. And in someone vulnerable to atrial fibrillation, the change can occur within hours. One carefully monitored study of people who already had intermittent atrial fibrillation found that an alcoholic drink was associated with approximately twice the odds of an episode during the following 4 hours. Two or more drinks were associated with more than 3 times the odds. Those findings apply specifically to people with known atrial fibrillation and should not be generalized to every person who drinks, but they reveal something important. Your final drink may be finished. Your heart may only be beginning to react. Tonight, you will learn how a bedtime drink can affect your heart rhythm, how atrial fibrillation can lead to a stroke, why alcohol may worsen sleep apnea, which medication combinations deserve special attention, and what to do instead if you have been using alcohol as a sleep aid. Stay until the end, because the most dangerous mistake is not always drinking itself. It is ignoring the warning signs because they appeared during the night and disappeared by morning. A quick note before we begin. Senior Insight Guide provides general educational information, not medical advice. Nothing in this video is a diagnosis or prescription. Do not stop medication, change anticoagulant treatment, or abruptly stop heavy daily alcohol use without professional guidance. Before we continue, tell me your age and whether you have ever felt your heart race, flutter, or skip beats at night. Consider an illustrative example. Imagine a 71-year-old man named Thomas. Thomas has high blood pressure and type 2 diabetes. Several years earlier, his doctor also mentioned that he had experienced a brief episode of atrial fibrillation. Thomas does not consider himself a heavy drinker. He rarely drinks during the day, but after his wife goes to bed, he pours himself a glass of whiskey. Some nights, one glass becomes two. He believes the alcohol helps him fall asleep. One evening, Thomas finishes his second drink at around 10 o'clock. He goes to bed 45 minutes later. At approximately 2 in the morning, he wakes with an unusual sensation. His heart is not beating steadily. It flutters, then pounds, then seems to pause. He feels slightly short of breath, but there is no crushing chest pain, so he remains in bed. After 20 minutes, the feeling settles. Thomas assumes it was indigestion. The same thing happens 2 weeks later. This time, the episode lasts nearly an hour. Still, he does not tell anyone because the symptoms are gone by breakfast. Months later, a routine heart monitor detects intermittent atrial fibrillation. Thomas's story is illustrative, but the pattern is medically plausible. Atrial fibrillation can come and go, and some people have few or no obvious symptoms. Alcohol is a recognized modifiable trigger in certain patients, which is why current atrial fibrillation guidelines recommend minimizing or eliminating alcohol for people with the condition. Thomas's mistake was not that he failed to diagnose himself. That is not his job. His mistake was assuming that a temporary nighttime symptom could not be important. A symptom can disappear. The underlying risk may remain. Your heart does not beat because someone winds it up like a clock. Every heartbeat begins with an electrical signal. That signal normally travels through the heart in an organized sequence, allowing the upper chambers and lower chambers to contract efficiently. Atrial fibrillation disrupts that organization. Instead of contracting in a coordinated rhythm, the two upper chambers, the atria, quiver chaotically. Think of a rowing team in a healthy rhythm. Every rower pulls at the correct moment. During atrial fibrillation, everyone begins pulling in a different direction. The boat still moves, but it no longer moves efficiently. Alcohol may influence this electrical system through several pathways, including changes in autonomic nervous system activity and the electrical properties of heart tissue. Regular or heavier consumption is associated with a greater likelihood of atrial fibrillation, while an acute drinking episode can act as a near term trigger in susceptible people. This explains why a person may feel normal while drinking and experience symptoms hours later. The drink is not sitting harmlessly in the stomach. Alcohol is being absorbed into the blood and affecting multiple systems at once. For a person without atrial fibrillation, an evening drink does not mean an arrhythmia will occur. For someone with established atrial fibrillation, a previous unexplained racing heartbeat, structural heart disease, or several cardiovascular risk factors, alcohol deserves more attention. This is especially true when several drinks are consumed close together. Atrial fibrillation is not dangerous only because the heartbeat feels uncomfortable. The greater concern is what can happen to blood inside the atria. When the upper chambers quiver instead of squeezing properly, blood may pool. Blood that remains relatively still is more likely to clot. If a clot leaves the heart and travels into an artery supplying the brain, it can block blood flow. That is an ischemic stroke. The American Heart Association explains that atrial fibrillation can lead to blood clots, stroke, and heart failure. It estimates that people with AF have roughly 5 times the stroke risk of people without the condition. Although an individual's actual risk depends on age and medical factors such as hypertension, diabetes, heart failure, and previous stroke. This does not mean every brief episode immediately creates a clot. It means atrial fibrillation deserves proper evaluation. Some patients require medication to control their heart rate or rhythm. Some require an anticoagulant to reduce clot formation. Others may not need the same treatment because their stroke risk is lower. That decision requires a clinician. Do not begin aspirin on your own because you suspect atrial fibrillation, and do not assume aspirin replaces an anticoagulant prescribed for AF. Current guidelines specifically state that aspirin is not an appropriate substitute for anticoagulation in patients who otherwise qualify for stroke prevention treatment. The protective step is detection, not self-prescribing. Alcohol is not transformed into a different substance when you turn 60, but the person consuming it may have changed. After 60, you are more likely to have high blood pressure, diabetes, sleep apnea, kidney impairment, heart disease, or a history of arrhythmia. You are also more likely to take several medications. These factors can change both the effect of alcohol and the consequences of an abnormal heart rhythm. Age itself is also associated with a higher likelihood of both sleep apnea and atrial fibrillation. Current AF guidelines include aging, hypertension, obesity, diabetes, and other cardiovascular conditions in the overall risk. Picture, while the National Heart, Lung, and Blood Institute notes that sleep apnea risk increases with age, this is why advice that seemed harmless at 40 may no longer be harmless at 70. Your body's margin for error may be smaller, your medication list may be longer, and a symptom dismissed as just feeling tired may represent low oxygen, low blood pressure, an arrhythmia, or a medication interaction. Alcohol may make you feel drowsy. That is not the same as producing healthy sleep. A person may fall asleep more quickly but still awaken during the night, breathe poorly, or feel unrefreshed in the morning. The National Institute on Aging advises older adults to avoid alcohol as part of healthy sleep guidance, even in small amounts. The crucial distinction is this: sedation turns down awareness. Restorative sleep supports the brain, heart, and body through normal sleep cycles. Alcohol can produce the first while interfering with the second. That creates a dangerous misunderstanding. The person says, alcohol helps me sleep. What they may actually mean is, alcohol makes me lose awareness faster. Those are not equivalent. If you repeatedly need alcohol to initiate sleep, the underlying problem may be insomnia, anxiety, depression, chronic pain, restless legs, medication timing, sleep apnea, or another medical condition. Covering that problem with alcohol can delay its diagnosis. Obstructive sleep apnea occurs when the upper airway repeatedly becomes blocked during sleep. Airflow stops or decreases, blood oxygen can fall, the brain briefly wakes the person enough to reopen the airway, and then the cycle begins again. Alcohol can relax the muscles of the mouth and throat, making the upper airway more likely to close. The NHLBI lists alcohol as a modifiable sleep apnea risk factor and notes that sleep apnea itself may raise the risk of hypertension, heart disease, and stroke. Picture your airway as a soft tunnel. While you are awake, surrounding muscles help hold that tunnel open. During sleep, those muscles naturally relax. Alcohol may relax them further. For a person with a narrow airway, excess weight around the neck, a large tongue, or untreated sleep apnea, that additional relaxation may be enough to worsen obstruction. The result may include loud snoring, gasping or choking, morning headaches, dry mouth, daytime exhaustion, difficulty concentrating, nighttime urination, or a partner noticing that breathing repeatedly stops. Alcohol does not cause every case of sleep apnea, but it may make existing obstruction worse. That matters because untreated sleep apnea is also strongly connected with atrial fibrillation. Current AF guidelines recommend screening for sleep disorder breathing as part of risk factor management. Now the pieces begin connecting. Alcohol may worsen airway obstruction. Airway obstruction can create predated oxygen drops and stress responses. Those stresses may contribute to blood pressure and rhythm problems. A habit meant to make sleep easier may make the entire night harder on the cardiovascular system. High blood pressure is one of the most important modifiable stroke risk factors. The American Heart Association's 2025 scientific statement concluded that heavy alcohol consumption, generally more than 2 drinks daily, and binge drinking are consistently associated with worse cardiovascular outcomes, including hypertension, stroke, arrhythmias, heart failure, and coronary disease. The statement also emphasizes that the cardiovascular effects of light to moderate drinking remain uncertain. This nuance matters. It would be inaccurate to tell every viewer that one glass of wine immediately creates a dangerous blood pressure crisis. It would be equally inaccurate to tell someone with hypertension that regular evening drinking is automatically protective, because wine was once described as heart healthy. The current evidence does not support starting alcohol for cardiovascular benefit. For someone who already has poorly controlled blood pressure, drinking heavily in the evening adds another variable. To an already vulnerable system, it may also lead to salty food, missed medication, reduced sleep quality, or dehydration the following morning. Those surrounding behaviors can matter as much as the drink itself. The correct question is not, is red wine good? The correct question is, given my blood pressure, medications, rhythm history, and sleep, is any amount of alcohol appropriate for me? This is the part I need you to take seriously. Researchers followed 100 people with intermittent atrial fibrillation using continuous heart monitoring and objective alcohol sensors. Among participants with known AF, one drink was associated with approximately twice the odds of an atrial fibrillation episode during the preceding 4 hours. 2 or more drinks were associated with more than 3 times the odds. The study was relatively small and included people already known to have atrial fibrillation. It does not prove that one drink causes AF in every older adult, but it provides strong evidence that alcohol can act as an immediate individual trigger for certain patients. A separate randomized trial studied regular drinkers who already had atrial fibrillation. Participants assigned to abstain or greatly reduce their intake experienced fewer AF recurrences and spent less time in atrial fibrillation than those who continued their usual drinking pattern. That is why the 2023 American Cardiology Guideline recommends minimizing or eliminating alcohol for patients with atrial fibrillation. Pay attention to nighttime symptoms such as a suddenly irregular pulse, pounding in the chest, unexplained breathlessness, lightheadedness, weakness, chest discomfort, sweating, or feeling that the heart is rapidly fluttering. These symptoms do not always mean atrial fibrillation, but they deserve evaluation. particularly when they repeatedly appear after alcohol. A smartwatch may provide useful information, but it does not replace a diagnostic electrocardiogram or medical assessment. Record when the symptoms started, record how long it lasted, note what you ate or drank, and contact your healthcare professional. Many older adults take several products in the evening: a prescription sleep medicine, an over the counter antihistamine, an anxiety medication, an opioid pain reliever, a blood pressure tablet, a heart rhythm medication, or an anticoagulant for atrial fibrillation. Alcohol may intensify drowsiness and dizziness caused by some cold, allergy, sleep, and pain medicines. The National Institute on Aging warns that alcohol can interact harmfully with common medications and that older adults are particularly likely to be affected because they often use multiple drugs. The immediate result may be more than sleepiness. It may be confusion, poor balance, a nighttime fall, failure to recognize a stroke symptom, or accidentally taking the same medication twice. Do not guess whether your medications are compatible with alcohol. Ask your pharmacist to review the exact products, include supplements and over the counter medicines. Do not say only, I take a sleeping pill. Bring the bottle or provide the precise name and dose. And never skip an anticoagulant merely because you consumed alcohol, unless a clinician specifically tells you to do so. Missing anticoagulant doses can leave a person with atrial fibrillation less protected from clot-related stroke. A bedtime drink deserves particular caution when you have known atrial fibrillation or atrial flutter, a previous unexplained racing or irregular heartbeat, high blood pressure that is not well controlled, a previous stroke or transient ischemic attack, heart failure, diabetes, untreated sleep apnea, loud snoring with nighttime choking, a prescription anticoagulant, several sedating medications, or repeated falls. This does not mean everyone in these groups has exactly the same risk. It means that decisions should be individualized. For someone with AF, reducing or eliminating alcohol may be part of formal rhythm management. For someone with alcohol dependence, abruptly stopping without medical guidance may be unsafe. For someone who drinks occasionally and has no cardiovascular condition, the risk discussion will be different. Precision matters. Fear does not replace it. In the United States, a standard drink contains about 14 grams of pure alcohol. That is approximately 12 ounces of regular beer, 5 ounces of wine, or 1.5 ounces of distilled spirits. Home pours are frequently larger than one standard drink. A large wine glass may contain 2 servings. A mixed drink may contain several shots. The CDC defines binge drinking as 4 or more drinks for women, or 5 or more for men during one occasion. Heavy drinking is generally 8 or more drinks per week for women, or 15 or more for men. These population definitions do not establish a safe amount for someone with AF, hypertension, liver disease, medication interactions, or previous stroke. For people with atrial fibrillation, the more relevant guideline is often minimization or elimination. Your personal limit may therefore be lower than a general public health limit, or 0. That decision belongs in a conversation with your clinician. First, stop treating alcohol as sleep medication. That does not mean every person must make an abrupt change tonight. It means the goal of drinking should not be to sedate yourself. Second, identify what the drink is solving. Are you unable to fall asleep? Are you awakening at 2 in the morning? Are you anxious? Are you in pain? Are you lonely? Are you struggling to breathe while lying down? The correct solution depends on the real problem. Third, establish a calm pre-sleep routine. Dim bright lights, keep a regular bedtime, avoid heavy meals immediately before lying down, discuss persistent pain or urinary symptoms with your clinician, and ask for a sleep apnea evaluation when you snore loudly, stop breathing, gasp at night, or remain exhausted despite spending enough time in bed. Fourth, track the relationship between alcohol and symptoms. For 2 weeks, write down how much you drank, when you finished, when you went to bed, whether you snort or woke gasping, whether you experience palpitations, your morning blood pressure. When your clinician has advised home monitoring and how rested you felt, do not deliberately drink to test whether it triggers an arrhythmia. Observe normal patterns and bring them to your appointment. This safety line is essential. If you have been drinking heavily every day, need alcohol to prevent shaking, or have previously experienced withdrawal, do not attempt an unsupervised sudden stop solely because of this video. Alcohol withdrawal can include sweating, tremor, anxiety, rapid heartbeat, vomiting, confusion, hallucinations, and seizures. Severe withdrawal can become life-threatening and may require monitored medical treatment. Speak with a healthcare professional or an addiction treatment service. Call emergency services for seizures, hallucinations, severe confusion, fever, or an irregular heartbeat during suspected withdrawal. Reducing cardiovascular risk should not create a different medical emergency. Call emergency services immediately when you or someone near you develops possible stroke symptoms. Remember FST, have face drooping. Ask the person to smile. Is one side uneven? A, arm weakness. Ask the person to raise both arms. Does one drift downward? As speech difficulty, is the speech slurred, confused, or strange? T, time to call emergency services. Do not wait for the symptoms to improve. Other warning signs may include sudden vision loss, severe imbalance, one-sided numbness, confusion, or a sudden severe headache. A stroke occurs when brain blood flow is blocked or a blood vessel ruptures, and brain cells can begin dying within minutes. Do not allow the person to sleep it off. Do not assume the symptoms are intoxication. Do not drive them yourself when emergency transport is available. Note the last time they were known to be normal. That information can affect treatment decisions. Also seek urgent care for sustained rapid or irregular heartbeat accompanied by chest pain, fainting, severe breathlessness, weakness, or neurological symptoms. So, what is the bedtime habit that may contribute to a stroke triggering chain? Drinking alcohol to relax or fall asleep, especially consuming several drinks close together, and especially when you already have atrial fibrillation, high blood pressure, or sleep apnea. The accurate chain looks like this. Alcohol may trigger an atrial fibrillation episode in a susceptible heart. Atrial fibrillation can allow blood to pool and form a clot. A clot can travel to the brain and cause a stroke. Alcohol may also worsen sleep apnea and is associated, when consumed heavily or in binges, with hypertension, stroke, and other adverse cardiovascular outcomes. But remember what this video does not claim. It does not claim that one drink guarantees a stroke. It does not claim that every nighttime palpitation is atrial fibrillation. And it does not tell anyone with heavy daily alcohol use to stop abruptly without support. The safe plan is do not use alcohol as a sleeping medicine. Ask whether your health conditions or medications make alcohol unsafe. Tell your clinician about nighttime palpitations. Get evaluated for possible sleep apnea. Take prescribed heart and anticoagulant medications exactly as directed, and act immediately when stroke warning signs appear. The habit may feel ordinary, the timing may feel harmless, but when your heart rhythm, breathing, and blood pressure are already vulnerable, the final drink of the evening may place more stress on your body than you realize. If this helped you, type heart in the comments. Share it with someone over 60 who regularly uses a drink to fall asleep. Subscribe to Senior Insight Guide for calm, research-based explanations of the everyday habits that affect your heart, brain, and independence. In the next video, we will examine the nighttime heartbeat symptom many older adults dismiss as anxiety, even when it may be atrial fibrillation. Take good care of yourself. You are worth the effort.